delving into those. My name is Serfine Achieng Ouma, and our sign language interpreter this morning is Susan Thuku, and I'm having that very important conversation together with my guest for this first hour. His name is Peterson Wachira. He's not a new face to us. Peterson is the national chairman of the Kenya Union Clinical Officers. Thank you so much, Peterson.
And thank you so much, Serfine, for having me.
All right.
Yes.
So it must be a very tiring season for you. I was sharing with you this earlier before we began the program.
Yeah.
Just battling the COVID-19 pandemic. You are the frontline soldiers, and we depend on you a lot in this particular war. Let me just paint a picture of how the situation is as at last, night. In the last 24 hours, I believe we'll be receiving, new figures today. But as at yesterday, the positivity rate in the country stood at 12.5%. Yesterday, the Ministry of Health recorded 591 new cases from a sample size of 4,737. So far, 3,970 people have died. And if you look at the vaccination, exercise that is currently ongoing, 1,726,937 people have been vaccinated so far. We will be looking at, whether this is good enough for us or what is happening in just a bit. But Peterson, just as an opening question into this conversation, a positivity rate of 12.5%. Last week it went as high as 18%. And we have been recording this double-digit positivity rate for quite some time. What are you reading from this? Are we winning or are we playing catch-up?
I think what we can say is that it's definitely true that we are in the fourth wave. And a wave is defined by what we are seeing currently, that we are having a positivity rate that is going higher. We must also note that what we are seeing is just but a sample of the population. And sometimes all we would be able to tell is that we have a surging rate of infection, and that is the positivity rate. Forget the numbers, because 12, 18 depends on so many factors. One factor being, we are not testing everyone. If we were to test everyone, if the tests were available to any person who needs them or who wants it, then we would say that that's a true positivity rate. But currently what is happening, the people who are being tested are people who have to be tested. Either you are going back to work, you are traveling out of the country, or you are sick. So sometimes it's quite difficult to tell. But one thing that we can definitely tell is that the positivity rate is going up. And I think by now, every Kenyan knows somebody who has actually been hit by this virus. And I think we are past that question of whether actually COVID is real or not.
But you'd be surprised there are people who still feel like this is a game being played. There are people who still don't believe that there is COVID, even as we are speaking this morning. Yeah,
actually I've seen even on social media, some people saying that once we are heading to the end of the curfew period, the positivity rate will rise and then we'll go back. But I don't think that is the true picture. There may be a coincidence, but for real, and for us especially who have been interacting and treating and taking care of these patients, we know that COVID is real. And I need to warn Kenyans that especially this Delta that we are dealing with, that we don't even know if it's a variant of the Delta from India, number one, is very contagious. Number two, it progresses very fast. So we are seeing so many people who are actually requiring that hospitalization. And what we have been trying to do all this long is to ensure that we have very few numbers coming to hospital who have oxygen demand, so that we actually do not lose people because we don't have resources. Because I think we have come to that acceptance that we do not have enough resources to be able to take care of our people. So people must know that COVID is real. I think most of us have now interacted. I know relatives. My own dad was in HDU for like 2 weeks. And I think Kenyans, we have this, we want to see it for ourselves so that you can believe.
And that's the worst mistake anyone can make, to learn from something when it is happening to you. We don't have this culture of learning from other people's mistake. That's the worst, I would say, I would term it as an injustice that we can do ourselves as a country. Let's wait and see.
Actually, the wise people will say that you are foolish if you can be able to see it, but you cannot believe it until it happens. You suffer yourself. That is defined as foolishness.
Let me take you back a little bit before we talk about this Delta variant. You say that this could not be the true representation of the situation as it is. Are you basing this on our testing capacity? If so, how many people are we supposed to be probably testing per day to say that we have met that threshold that can give us that true picture of how many people are positive and, you know, what's our positivity rate as a country? Where should we be at to say that we are safe at this point?
What I'm trying to say is, in an ideal situation, the test should be available to anybody who wants to be tested.
Whether you're sick or not?
Of course, when you're going to be tested, you are going to have your own suspicion.
Okay.
But currently, the tests that we are conducting, because of limitation of resources, we are only testing to those who really need them. And some of them are actually paying for them. And you know, if you actually have to pay for that test, it means that we are excluding a certain percentage of the population. So the only people we are testing, it's either you have gone to a hospital, you are sick, or your work requires that you be tested, or you are traveling out of the country. These are the only 3 categories that we are testing. But we know that with COVID-19, a majority of the people will actually be asymptomatic to mild symptomatic, having a few symptoms that cannot actually even take you to a hospital. So the whole of this category, we're actually missing them. And so the positivity rate we are seeing is only from these 3 categories of people who are being tested, who are a minority. And that is why I'm saying, forget the numbers in the positivity rate. The only thing that we need, that is definitely true, is that the positivity rate is rising. And that means that that surge means that we are actually in the 4th wave.
All right. Yes. So the situation could be different from what we really are getting. We will be engaging more on that, but of course we're also following up quite a number of activities for you, including the fact that this particular morning there is the flagging off ceremony of Green Zones Development Support Project Phase 2 project vehicles currently happening at the Kenya Forestry Services Headquarters, Karura Sports Ground, right here in Nairobi. I just want us to quickly cross over to that particular function, and then we will I'm guided that we will be heading there any minute from now. We have our reporter there, Ben Troy Njue, following up that for us. As soon as he's ready for us, we'll be crossing over live to him. And then we come back to this particular conversation in a studio. Right now, we are talking about the COVID-19 situation in the country. And I'm hosting this morning Peterson Wachira, the chair of the Kenya Union of Clinical Officers in the country. So, Peterson, there's been a concern about how fast this virus is spreading in the country, especially now that you're dealing with the Delta variant. I don't know whether it's the virus itself that is spreading faster than the other variants, or it's just our way of life and how we have sort of put our guard down in this, in this battle against the pandemic. What could be the issue here?
I think the issue is that it's a multifactorial issue. Yeah. Number one is that, as I said, the Delta virus has been seen to be more contagious, means it's highly infectious, even more than the variants that we have had prior. The second thing is that we are not disciplined, both us as the public and even our leadership. And I say our leadership in quotes, because sometimes what defines leadership does not fit. And I'm saying this because, number one, for so many months, we have known that there is a variant that is more infectious, more contagious, progresses faster as a disease. We also knew that it came to Kenya, and we started reporting from Kisumu. But even from when it was in Kisumu, you have seen our behavior as a nation. Both we as the people and our political leadership. We have been bringing people together, sometimes without even observing the protocols that we have put in place for ourselves. Because we must understand that whatever protocols that we put in place for containment They are not for the government. They are for us all.
Yeah.
So when you see crowds being pulled together in Kisumu without even masks, when you see in by-elections people being brought together, and somehow it's like we have accepted that during political moments we can be able to suspend these containment measures and we just let it loose for some time.
So it works for some people sometimes, but it doesn't.
It works for some people. You even saw during the safari rally in Naivasha.
All right, Peterson, we were just talking about the spread of this particular virus, and I just wanted us to sort of dissect the recent, we've seen quite a number of political rallies that were lined up by political players in the country, and this, even the Ministry of Health the other day termed as a danger zone, and actually something that sort of, risked negating the gains we had made in the war against COVID-19. What would be your sentiments about why this is happening at the heart of, such a pandemic?
I think this goes far to show the kind of leadership that we have, that we do not have responsible leadership. Because responsible leadership means that before I look at my own interest, I want to look at the interest of the person that I'm seeking to lead. And what we have seen over the past several months is that our political leaders do not care about the people that they are seeking to lead. Because when you bring them together, and without even the containment measures, and you are encouraging transmission of this virus amongst the people you are telling us you want to lead, then that is not responsible leadership. But on the other side, this Kenyan who is attending these meetings,
I was about to ask you, are they innocent in this?
It also tells you something, that these people do not feel that they actually own the containment measures, and they do not hold them with the seriousness they deserve. So that tells you that there is somewhere that we are failing, and especially as the Ministry of Health and the county governments. And I must say that we are working in a very difficult environment where the health is devolved, and we have so many centers trying to do something, and sometimes we lack coordination. When you are dealing with a pandemic of this kind, there are certain things that must be in place to ensure that you have a whole community approach. And these things are, number one, you must have enough capacity to ensure that you can be able to isolate and treat the people who fall sick. Number two, you must be able to reach to the community mobilization. You must do proper, robust community mobilization. This is what we are lacking. Then you must be able to do surveillance. You must be able to do surveillance so that at any given time you can be able to tell which parts, and in these parts what percentage of people are we having, and so that informs the containment measures and whether you are going to limit more in some areas more than the others. Now the problem, especially when you are feeling in the community mobilization, and this is where I think we have failed much as a country, especially looking at how we started. We were enforcing using police. We decided to police these protocols instead of sending the people who are experts, the public health experts, to the community to talk with the community and sit with them, make them understand, and even make the community be part of generating these containment measures so that they feel ownership of these measures. And that is where the problem now lays, because you can see, if you're walking in the streets, you're having some people wearing their masks, but they are on their chins because they don't feel that they actually need that mask. They feel that it's the policeman who needs to see them wearing that mask. And that is a failure. It's a failure of how we are taking care of a whole community approach, and especially that pillar of community mobilization and communication. Community mobilization does not end at informing the community. You must be able to go sit with the community, talk in the language they understand, make them feel according to their own logic, and so then they can be able to understand and own and utilize. And if that does not happen, they will continue going to these political rallies, they will continue getting infected and dying, and it will be a whole circus.
Hasn't that been what the Ministry of Health, hasn't that been what they've been doing all this while, telling us how serious this situation is, warning about laxity in terms of observing these protocols, just telling us about even the situation in hospitals and how we are having an overwhelmed health system. How should this message then be different so that people can really understand that it's not about what the government wants to do, but it's about what I can do myself to be safe? Is that not something that they've been doing all this while? From where
I agree that there is something they have been doing.
Yeah, telling us about how serious the situation is.
But how far does that communication go? Which languages do you use? How do you deliver it? How many people will be watching news at 7? What percentage of Kenyans? And what percentage will be out in the market trying to earn a living and are trying to sell their wares until 10 p.m.? How are they going to get this news? And that is why sometimes you just have to have the experts on the ground, not even through the media now, on the ground talking with people. I'll give you an example of West Africa, because I went there when we were fighting Ebola. And we regularly and constantly had a communication and community mobilization team out there with loudspeakers, with pamphlets, with everything that you need, the IACs, so that they can engage the community. You can sit with them, you can be able to approach them from where they are, you can be able to reason with them. Our logic is very different. How you approach the middle income society is not the same way you're going to engage with the lower income community. And what they consume in terms of news, in terms of the languages they use, it's very different. So you must have some people with a local touch, the people they can be able to believe, constantly and regularly engaging these communities so that they can be able to own it up. But when you tell them how serious it is, sometimes they will not understand, because you cannot be able to show them what is happening in hospitals. And sometimes for them, we are a very political country. Some of them think that you are playing politics. But when you bring people who are apolitical, who they believe they are experts, of course they are going to understand and believe more.
All right, we get your point. So a change of strategy is needed. Constant, I've heard you talk about constant communication, and then how we communicate this information should actually change and cater for those who are in the low income society. Maybe even translate this into their vernacular, languages, get to their houses and get people who they can identify with in their communities to break this down for them. I like that approach. I also want us to talk about now the situation in our hospitals. You are the frontline soldiers in this battle against the COVID-19 pandemic. The Ministry of Health is telling us things are not very good. The CS the other day was actually saying that if you get sick today, you're highly likely to miss a bed and to miss, the oxygen ventilators. Tell us, how bad is the situation across the hospitals?
And I think that was very sincere from the CS, and I can assure you that that is actually the case. And in the next 1 to 2 weeks, actually, I don't think within the metropolis you'll be able to even get a bed from any hospital. I have had relatives that have been trying to secure beds for, and we have had to settle for some private hospital somewhere because we couldn't actually be able to get any in the public. And sometimes even the quality you are looking for, it's not easy for you. But where did the rain start beating us?
Exactly.
As a country, I think we must own up to the challenges that we do have. I think prior to the last decade, there was a general neglect to the health sector. I think it's fair for me to say that. And this I mean, we didn't have enough resources in terms of the expertise, the skills. We didn't have the equipment, and we didn't even have the infrastructure. I think it's the first time that we are seeing a government put health as one of its agendas. We didn't see that in the past. And I think we must give credit to the current administration and His Excellency Uhuru Kenyatta, because they have tried to do something. So what we had is that the equipments were lacking. That is why by the time we were being hit by COVID, I'm telling you the number of ventilators and even the people we could give oxygen, just oxygen, which is a normal thing. It was very little. The other thing is we have a dire shortage of human resource. And you know, even according to WHO, they will tell you that there are 6 or 8 systems, depending on where you are looking at it from, that make a good health system. But within that system, the human resource is the core system that runs the others. Our own government and our ministry has owned up to the challenge of a dire shortage of human resources. It is documented in government documents. In fact, in 2013, Kenya was represented by the CS Health then, CS Macharia, in Brazil, in a WHO Human Resource for Health conference. And Kenya owned up to the dire shortage and the fact that it may prevent Kenya from offering that universal health coverage. And so the CS made certain commitments that you can actually Google and see, and they are signed, that in every year, Kenya is going to employ 12,000 healthcare workers, and these included doctors, clinical officers, nurses, pharmaceutical technologists, laboratory officers, nutritionists.
So that was to happen annually from 2013?
Annually
when
from 2013 to 2017.
Or to 2017?
Yes.
Have we done that?
If you can sum up the numbers we have employed since 2013 to now, currently 2021, they do not even aggregate to the numbers of 1 year as Kenya committed. Following that, in 2014, the Ministry of Health domesticated the same in what they call staffing norms and standards. And they provided on how they were going to increase the numbers so that by 2018 they would achieve that. For an example, to bring it home, for just clinical officers, they were supposed to have 16,148 in place. Currently, we only have about 6,500. We are not even halfway what we committed as a country.
In studio, we have been talking about the COVID-19 pandemic. A lot seems like we have a lot of ground to cover going forward. We have quite a number of hits and misses here and there. And I've been having this very important conversation with Peterson Wachira. Peterson is the national chairperson of the Kenya Union of Clinical Officers. Thank you for staying on, Peterson. And we were just talking about the status in the hospitals and how bad the situation is. And you cited a big problem, the shortage of the human resource in our hospitals in the country. And I wanted just to understand how this translates to our ability to offer quality healthcare to the populace, and especially at the heart of such a pandemic. How serious is a problem of having a shortage of staff in our hospitals when you're battling such a pandemic?
Yeah, I think now that is what actually brings it home.
Yeah.
Because what happens is, number one, you have a shortage of human resource. That has consequences. One of the consequences is that you will not have enough people going back to improve on their skills and specialize. So you have a few specialists. Number two, the people that you are having seeing your patients may not actually be able to give the best they can. And in some point, they are either going to misdiagnose or they are going to miss a diagnosis. They give a wrong diagnosis or miss a diagnosis that is there. And I want to give you an example of my own father. You remember we went on strike last year and we were simply telling Kenyans that we are doing this so that you do not have to die. The very reason that I led my people on strike so that the government can sort actually came home to haunt my own dad. So my father goes to 3 hospitals, 3 different hospitals. Sees 2 clinical officers, is seen by a doctor, is seen by several nurses and a nutritionist over 3 days. None of them would actually pick that this 77-year-old man is having difficulties in breathing, something that you can be able to see from afar. So I actually noted from the phone and I told him, no, you are not okay. And I took him from home, took him to hospital and told them, you have to test this man for COVID And by then...
So you're the one who demanded for the test to be done, the COVID-19 test to be done?
I actually left Nairobi to Nakuru, where my father lives, took him to hospital, a public hospital, demanded for that test to be done, because I could tell from the phone that he was actually gasping. Sometimes he would actually pause to catch his breath. So it came out positive. Unfortunately, even my mother came out positive by then. By then, my dad's lungs had been destroyed 68% as per the CT scan, and his oxygen saturation was around 56. So what would have happened had I not intervened? He would actually have collapsed in the house, because he was just sleeping in the house. And by the time I was actually going to take him, he could not recognize me until I talked. So he could have just collapsed and died in the house. And so, as a responsible leader also, I wanted to just know, why would all these medics would have missed such an overt symptom or sign from such a patient?
What were they telling you?
And so I decided to go and interact with them and just experience the environment. And I'm telling you, I found a clinic officer in a day seeing about 130 to 150 patients. According to the World Health Organization, you cannot be able to see more than 35 patients in a day. So this is even more than double. Above, you are actually just clearing and forwarding. You want them to just get out of your space. And so you're already fatigued. You cannot even tell, because the moment that patient is coming in, you want them out. You want to clear the line so that you can actually relax. And that is where the problem is, that actually some of the cases, because we have so many cases who have collapsed on the streets, at home, and I know them. I saw them in Nakuru. I saw them even in my home area. People who just collapsed, and they were later diagnosed to have died of COVID-19.
First of all, sorry for what happened to your dad. Yes. But I'm trying to imagine, for you, you're lucky you were a medical expert, and probably you could tell that something was off over the phone, and you traveled to go there and find out. But how many Kenyans are in that particular position? What could be happening elsewhere? Somebody who cannot even be able to tell, like yourself, who is a medical expert. Does it mean that we have so many of such cases in the country?
And actually, that is the point. That if you have a shortage of human resources, because sometimes Kenyans do not understand, those are the repercussions that you are going to get. For those who do not understand, who will not get a medic to be able to intervene and save them, they are collapsing and they are dying at home. And it's something that is there. It's something that Kenyans will be able to tell you that they have actually experienced the same. Some of them are actually being taken to hospital in the last stages, when they are very bad, and sometimes it's very hard for them to recover. So when we as the unions, we go out and we try to get the government to employ more, we are not looking after our own welfare. We are looking at an ideal situation where we can be able to offer the best quality of healthcare to Kenyans, as envisioned under Article 43 of the Constitution. And sometimes Kenyans mistake us to be entitled. And actually, going forward, if we have real human rights activists, we should see human rights activists, especially now that COVID has actually portrayed the importance of the health sector, especially in the progress and development of a country. We need to see groups that are non-medical, that are now taking up activism to ensure that we have everything we need in the health sector, so that Kenyans can be taken care of.
All right.
As we head to the UHC, we cannot be able to achieve universal health coverage if we are not going to have the requisite numbers in the right skill mix that we need, so that we can be able to deliver access to all Kenyans.
All right. Yes. Peterson, as you're about to wrap up this conversation, what about now the welfare of the frontline soldiers? There was a time, and I believe you really advocated for healthcare workers to work in conducive environments, especially right now. They were decrying of lack of PPEs. You've just talked about the shortage that comes with fatigue and all that. Have things improved? Things
have not really improved, and it's unfortunate to say that in Vihiga, we have about 122 officers who have been serving for the last 2 years without salary, despite a court order directing the county to pay. We still have officers in Kisii who were actually dismissed from service because they asked for PPE during the last strike that are not yet back, yet we are having a shortage. Then, you remember that we entered into an agreement with the Ministry of Health. That agreement was giving us a comprehensive medical insurance cover that caters for you when you fall sick, and a comprehensive group life cover that compensates your family in case you pay the ultimate price. The counties declined and refused. So as we talk now, the counties do not actually have a comprehensive cover for their people.
So if you're a healthcare worker, if you fall sick today, what happens?
If you are under the counties, then we are having to contribute, and we have them actually. We are having to contribute, and this is a simple thing that a government can be able to do even through the NHIF. But the governors deliberately decided that they cannot agree on those aspects, and that is why if the situation continues like this, you will see a lot of lethargy, especially in the counties. In the national government, the CS for health signed, and we are covered, we are completely covered, including those who are on short-term contracts. But under the counties, if we get several people falling sick, God forbid, we get somebody dying. We have already lost. We lost a lady from Mombasa. I know from Kajiado, we are having a lady who was pregnant, and now she is hospitalized. She's actually in the ICU together with the child because of COVID. She's a medic. She's actually a clinic officer. If these things continue and we do not have the requisite covers, I can assure you, you are going to see people deliberately refusing to go to work because they feel that the government has not protected them enough to be able to treat Kenyans.
All right. Yes. I want you to, if you're given a chance to sit down and advise the government on the way forward on this, we are not looking at a very promising positivity rate of 12.5%, and it could go higher, it could go, lower. It depends on how best we are going to manage this pandemic. What is it that you tell us to do different? What are some of those things that you'd list and say, let's do this for us to be able to manage this pandemic?
Very good. I think what I would say, number one, let us ensure we have a whole community approach. How do we ensure that? We do enough community mobilization and communication. And by the way, community mobilization does not stop at mobilization, at communication. You deliver the information, but there are other things you must do. You must ensure the community understands that they have to take care of each other. Until you reach that point when your neighbor asks you why you're having so many people over and you're going to get infected, or where you don't have hand washing, then you know there you're achieving something. Number two, you must take care of the healthcare workers because they are the first and they are the last line of defense when it comes to a pandemic like this. How do you take care of them? Ensure you have enough numbers, because we do not have a shortage of healthcare workers in this country. We only have a shortage of recruitment of these healthcare workers. And I'm surprised that now we want to ship them out instead of first ensuring that we have enough in the country. Number two, can you ensure that their welfare is well taken care of? They are well sensitized, they have the requisite medical cover, the group life cover to compensate in case they die. And lastly, can you make them feel appreciated when they ask for protection, like what we did last year? That is not the time for government to come out with batons and hit their own soldiers who are fighting. That is the time to sit with them, understand them, and reason together with them, because these are the experts, and ensure that you employ the expertise that is needed. We have a very great shortage also of the public health workforce. And these are the people who are supposed to be out there in the markets, in the streets, doing this community mobilization.
Thank you so much. Thank you so much, Peterson. Of course, this is a conversation that we cannot conclude in one sitting. It is something that we really need to, keep on empowering the populace about. Thank you for creating time and the much that you've shared with us on how best to battle this pandemic. I've been engaging Peterson Wachira, the National Chairperson of the Kenya Union of Clinical Officers. Thank you once again for your time.